seen me enough. Jennifer Stanley, I'm y'all's president. You chose me for a second year. So a few more months and then I'll be turning it over. But I'm also compliance consultant. Compliance consultant. Let me know if y'all need me to hold it up to have this. But I got a lot going on up here.
Yes.
Is that good? Can we just look at the camera?
Yeah.
As
long as you project your voice so we can get the audio.
Okay. Wait, where's my drink? I have 3 of them, but none of them are here. Okay, compliance consultant with the Lara Group. Been doing employee benefits since I got out of law school, out of the bar, walked into a broker's office, and he took a chance on me. And what was really cool is I got to say I don't know a lot because it was right when ACA was starting. Sometimes I feel like that's our world again now with the COVID stuff, the transparency and coverage, Consolidated Appropriations Act. So I really wanted to do a more of a deep dive into those 3 areas. And this presentation is my first time to flip through all the slides. I had high hopes of doing CE, but the more I got into the weeds, and I'm pretty good at the weeds, the more I got in there, the more mad I got. I mean, mad, like really mad. And I'll tell you a little bit about that as we move on. And I'm not going to do to you what others do to me, where you go to a presentation and you go through all the stuff you already heard, right? Like I really want to hit the COVID stuff, but I'm going to do the CAA and transparency and coverage to start with. And if we have time, we'll hit the COVID. There's some important stuff in the COVID that has been overlooked. But I know we want to get all of it. Sorry, it takes me a little while to warm up. Okay, so we are going to, where's my ENT? Start with the transparency. And transparency comes in 2 forms. One is the transparency and coverage final rules, and those were through CMS. And the second is the Consolidated Appropriations Act of 2021. There is so much to say that I won't say all of that every time. I'll shorten it. So November 2020, we had the TIC rules. They were released, and that includes several provisions on group health plans, carriers, hospitals. And then a few weeks later, you had the CAA of 2021. That was December 27th. That's why that date matters. It was when it was signed into law. And what's interesting about the CAA is it applies to plans under the Public Health Service Act. I'm talking too fast. Slower, faster. The Public Health Service Act, the ERISA, and the tax code. So it is pulling in all plans. It is pulling in fully insured, self-insured, government, quasi-government, church plans if they're subject to the code, which most are, grandfathered plans, grandmother plans. So that's pretty big on the CAA side. Our grandfathered plans got to get out of some of this stuff on the transparency and coverage. They get roped back in on the CAA. So the first thing that y'all had happen, and I know this is free. Oh my gosh, I don't know how to advance the right slides. I'm advancing. There's a lot going on up here, guys. It's a little dangerous sometimes in my head. The first thing we just passed was our machine readable files, right? So big rush, you had to get your MRF stuff, 3 separate files. That's not you. Okay. And there was debate on whose responsibility was it. For our fully insured plans, it is the carrier's responsibility. But and then for our self-insured, it falls back to the employer. So what we have going on here is every month, beginning June 1 for our calendar year plans to our 6/1 renewals, those machine readable files, those links should be publicly facing and downloadable. But do not download them because they are called machine readable files. They are not people readable files. Special software is needed to do these. And then our self-insured, you know what? Oh. our self-insured side, you have they can contract to have the TPA maintain these, and that is what a lot of employers did. The TPA said, no, we'll maintain them, and that's great. But what if the TPA forgets, or what if they're not updated? The responsibility will fall back to your employer of the self-insured plan. So what we want to have happen is the self-insured plan can put the link that the carrier TPA provides on their website, probably in the footnote or something, that then links back to what the TPA is updating monthly. And if they do that, and if they have an agreement saying TPA ASO is going to do this, provide this service, then if it doesn't happen or doesn't happen properly, the employer plan sponsor can get indemnified from that TPA. So little side note there, self-insured, it will fall back, and that's going to be a recurring theme on our self-insured, which includes level funded plans, guys. So I don't sell stuff. I mean, this is me, I don't sell. So as we're talking about level funded, please keep in mind these things apply to self-insured plans, and a self-insured plan is a level funded plan. All right, when we're talking about a lot of this stuff. Am I wrong, Cynthia?
Yeah, they're not level funded under insurance law. Level funding is subject to the grade.
No, it's for both, right? But when we're talking about ERISA, and when we go through the RHDC, it even says, like on that reporting, when we get to the CAA, section 204, that level funded are going to be treated as self-insured for the RHDC. So when we're under ERISA, we talk about that. So that's your TIC. Grandfather plans, again, are part of that. Let's talk about this. I don't know what y'all want me to call it. I'm going to call it the RXDC. Your TPA, VBM might call it your Section 204 reporting, and that's because I jumped to the Consolidated Appropriations Act in Section 204. There are 4 provisions of transparency in the Consolidated Appropriations Act. There's also the No Surprises Act, which is Title 1 of that law. But this puts us in Section 204. The original due date for the first reporting was December 27th, 2021. And again, that's 1 year after the law was signed. Well, some lobbyists did some really good work, and some agencies didn't get the things written the way the lobbyists wanted them, and so they fought a year. And that's the truth. I found that out yesterday. So this now pushed us back to December 27, 2022. We are reporting on we are reporting on calendar year 2020 and 2021 for this RXDC. Okay, so that's important. It is not plan year driven. Going forward, every other filing must be submitted in full by June 1st of the following year. So our 2022, what does this mean? It means our self-insured, level-funded employers are having to sort out 3 years of paying for, in a lot of cases, this type of reporting. You must report. Again, this is to the Public Health Service Act, HSA, that's our government plans, grandfather, grandmother, private, public carriers. Everyone's reporting this. This is transparency. It does not include your account-based plans, your EAPs, doesn't include your supplemental retiree-only plans, wellness programs, so long as there's not a claim tied back to one of these reporting things. You've got nicotine patches as part of the wellness program that would need to be captured. Medicare Advantage and Part D doesn't apply to those. Everyone else, you're in. For our fully insured, and as brokers or consultants, let's think, right? We're doing 2020 and 2021. So it's not enough to know where's your client now on their funding, right? You need to know what were they sometimes 2019 if they had a non-calendar year plan. And but for sure 2020 and 2021. So there could have been some changing in funding going on in the last 3 years. For the fully insured years, the carrier is doing the reporting for the most part. You still might need to keep in touch with your carrier. For our self-insured level funded, we have could be the employer plan sponsor. It could be your PBM, TPA, it could be third party. Doesn't really matter who it could be, but it's all got to get done for 2 years and then every year going forward. I put this right here. Do these people provide a compensation disclosure? We talked on that back in May, right? Beginning plan years, contract years of this past year, compensation disclosures. I'm curious if our TPAs, PBMs are doing what we did and proactively giving our employers what we make on what we make. Right? That's what we did as brokers and agents. Y'all remember that? Y'all done that? Right? Let's see if our PBMs and TPAs are going to do the same thing. Let's encourage them to do the same thing. More importantly. Okay? Let's all get naked and show our stuff. Pretty much. Like we're going to learn that that's not quite how it's happening in real life. Which is why I've gotten mad. So here's what has to be reported. Seeing this, it might not make sense, but it is the reporting entity, whether it's the carrier, PBM, TPA, or the plan sponsor. They must submit a plan list file. There are 3 of them. For our purposes, we are doing P2. And I'll show an example. We are just doing P2. Don't worry about P1 or P3, not us. Unless you're an individual. And I'm not talking to individuals. But if you're an individual, I don't even know. Scratch that. But P2 for this conversation. There are 8 total data files. And you can see there's D1, D2. Those are going to be, if you're carved out, primarily your TPA is going to have that information. And then D through D8, your PBM will have that information. It could be that you have the same TPA, PBM, and full service, situation. But if you don't, and if you didn't have the same full service situation for the last 2 or 3 years, there's a lot of coordination that needs to happen. Rita, are you wanting to say something?
No.
Am I doing okay?
Can I ask you a question?
Yes, you may.
Because, and it may have been, we're all struggling. Probably doing some else, but there's Texas was and California was ahead on transparency.
Right.
So these are the CAA requirements. Have you looked at coordination of those requirements, the record disclosures, Texas and the other states that you're operating with, or somebody putting that chart together?
I started that chart. I did not make this presentation, because I think this presentation has 60 slides. That's a very important chart. And it's also going to be an important chart when we look at the hospital, and I skipped over that. But remember, hospitals, right? And if y'all get your NAHU Newswire, one of the first articles of every week is hospitals still aren't complying. Well, no kidding. Because it's $500 a day if they get caught, which they're not. Or they have to show their stuff. They soon just pay the money. Employers can't do that. So, yes, I will do that. And same with the no surprise
notes, but that's really important. I'm trying to put a roadmap together for use it really useful and confirm those and share them.
That'd be great, absolutely. And that's one thing I do like about this association and being a part and involved is we get to kind of cross over, and it's okay. It actually is very okay. It's very helpful. It makes our industry stronger. So I'm going to go through. Do y'all want me to go through kind of what I've learned in filling out these things? Okay, because the instructions, they're easy to read, but they're not. So P2, and this might be something where even your fully insured plan might still have to fill out this list on the employer level. We're not sure, that could come later, but it is probably going to be needed to be filled out by one of us not by one of us, because I'm not sure about E&Os and all of that stuff. So, but yeah, the group health plan name, this is in a CSV format, which means if you have a comment in your name, you need to separate it out by quotation marks. So don't lose commas in there. Group health plan number, this is anything you want it to be. I thought about putting, if a layer group, we use UMR and then a card. So if I were doing my example, I would have put like your layer group and then the number code thing that y'all have on your sheets. It could be anything you want, but you need HIOS, that's just for our fully insured small group. Nobody else needs to fill this column out. And then the Form 5500 plan number is applicable. So this is the first 4 columns of the plan list. This is where it kind of gets a little interesting. States in which the plan is offered, separate with semicolons. You're using the 2 alpha state. If you're in Puerto Rico or other, what are those called? Territories, you do not have to report them. It's optional from a plan sponsor level. Market segment, these are your only choices. Small, large, self-funded, small. I'm not going to read them, y'all can read. But it does say if the plan is level funded, report as self-funded. So that is where you would put your market segment. Small, large, we're going with the 50. That's reasonable. I have not seen many questions on what market segment. I have not seen whether this is on control groups, but I'm seeing the instructions. I don't know that answer, but I didn't see it addressed. Plan your beginning date and end date. So when you download the Excel file, I'll put these slides, if y'all find them worth anything, out for you and link to some stuff, right? This is all linkable. It did not open in a month, day, year format. So you have to change that, which I thought was kind of neat, because it has to be submitted in this 224 format. If you are a non-calendar year plan, you're gonna have to take out 2 rows. And you can see how 2019, right, we've got a fiscal year 6/1 to 5/31. The members, participants, belly buttons, your belly buttons as of the last day of the reference year, so 2020. Well, this first row right here, right, it didn't show, it ended in May of 2020, so there are 0 belly buttons as of December 31 because it didn't go that far. So you're going to do a second row of the plan year that captures that calendar year number. And I put 869 because we're going to talk about what a member is and how to calculate that. That comes up in some of the instructions. Still going on our plan list, plan sponsor name. I mean, that's easy. EINs don't separate with a dash. Leading zeros if there aren't 9 digits. The plan doesn't have a self-insured, or is self-insured, leave some of it blank, right? I mean, some of that makes sense. If there's more than one, start with a semicolon. This is where I'm learning that we have a lot of employers that have your pharmacy carve out, and so it's important. I think we might have missed this. Your PBM, right? Because they got a lot of the reporting going on here, because this is pharmacy. Your PBM might email you and say, hey, look, we're going to do all this for you. We're going to do it for free, or we're going to charge you, $2,000 a plan year, or a calendar year, which means you've got experience coming up in 6 months for 3 years reporting. But what about the TPA, right? This PBM, if they're carved out, we're not going to know information that is in the D1 and D2 file, which I'll get to in a minute. Just know that if you're carved out, self-insured, you're going to have to piece this stuff together. Somebody's going to have to piece this stuff together. Questions on any of this? So here's what it could look like for a carved out. We've got Stanley Cup Health Plan, calendar year plan. The TPA will be listed, right? I've got the same TPAs listed, but then my TPA is only reporting for 1/1. They're only doing D1, D2, which talks about the premium lives, things of that nature. And then the PBM's doing the rest. So there will be zeros in the TPA file line. Am I getting too granular? I'll look forward. moving on. Okay. Yeah. Okay. So the point is, the real information, and this is what really made me mad, is this aggregation thing. I thought this was all about transparency, and it should be. But what is happening is CMS is allowing these things to be aggregated, and aggregated at many different levels. So you aggregate by the market segments, self-funded, individual, group, that type of thing. State aggregation, whether you're a single state or multiple state, it's usually your state it's issued or your principal place of business. But then this TPA PBM aggregation, they're actually encouraging the TPAs and PBMs to aggregate all their data, which is not helpful when a plan employer is trying to figure out where their money's going, right? Where are the rebates? We're talking about rebates. We're talking about hidden costs. We're talking about the shell game that pharma is. And so I think what I'd like to see happen is our self-insured plan sponsors probably did just fill over the barrel and feel that they had to go ahead and just go with the PBM or the TPA or both, pay the money for these 2 years and move on. I'm hoping that we can become more educated and teach employers maybe how to do this on their own, or find a third party who might charge a little bit more, but then we'll uncover where the data is going and what they're spending. Because here's the other thing. Your PBM and TPA, if the reporting entity uploads the file, this plan sponsor doesn't get to see it. It's confidential. So the only thing the plan sponsor gets to see is what the plan sponsor uploads. So if they're not uploading anything, they don't get to see anything. Again, that doesn't help us keep costs and know the costs. Rita, go ahead.
Yeah, I think the thing that I'm seeing with this is that the plan sponsor doesn't have that much granular data. So the TPAs are actually asking them for some kind of basic number information, and then they're doing reporting for them, which is very helpful. But once again, can't see the numbers.
Right, and
We
that's
really don't know what the numbers are, and so that's not really transparent. It's transparent from the PPA,
but it's not, right.
but it's not really transparent. Yeah.
Right. If the goal is to understand our drug spend and to understand how rebates work, how coupons work, and what employers are needing to are paying, right? This stuff's not free. Then doing this aggregate is not helpful. So to Rita's point of there are some numbers that have to happen. Yes, you might have to help an employer understand what is how do you average the premiums? How do you find the total member months, right? And similar to your MLR, which we don't do MLR, but carriers do MLR, so that's not new to them. But you're taking each month of the year, the calendar year, you're averaging it, and that becomes your total member months. And then you divide by 12 on a calendar year, and that gives you your number of life years. And those become the premium paid by members is reflected by the total member months. It's a denominator. I get that denominator, total member months denominator. Your numerator is your premiums paid by the member, premiums paid by the employer, and there's a column for life years again to get that number. You know what's really funny is that all this stuff is going to have to be reconciled. So we submit this, right, and then the Treasury is tasked with getting out a report in 18 months after submission. That'll be interesting. Really, again, I did get into the weeds on this. If y'all, I can move on.
I have a question about that member though, and I know you work with a lot of self-funded stuff, but my clients were self, and I had one that just could not get the numbers together. I mean, it just was like, not these numbers they don't know, but they just really had a hard time, and I kept saying, do you know what you booked for employer costs and what you took from payroll? I mean, that to me is the easiest way. What did you take from payroll? What did you book? Figure out the average, And they were like, well, we don't count it that way. So, I mean, have you guys seen kind of where people are struggling with that? Because, I mean, with self-funded, you have premium equivalent.
Right, and the
Which
premium.
you should be funding it, but a lot of self-funded doesn't.
So the instructions allow you to do the what you said is the COBRA minus the 2%. So if they're doing that properly, then that's accounting their ASO fees, their TPA fees, their accounting all those fees, and using that as their premium equivalent.
I just found that the account that I had, they don't book it that way.
Yeah, it's really interesting.
Like tracking it though. There's a difference between booking it and tracking it. So,
Well, that was just if they couldn't track it because they didn't book.
well, a lot of times what they're doing is outsourcing everything under the sun, so they don't have the data anywhere, and that's a much bigger compliance problem. But a couple of thoughts here that I celebrate for y'all, and that's part of the reason somebody like me comes, is y'all are working hard to do this. You guys are the downstream help for those employers. Look at what Jennifer's creating here. She's actually creating a template that helps her clients to be able to do these things and some of the education. So that's comment one, is that's why folks that, most of your clients are never going to be clients of ours because you're going to help them. And that's wonderful. The second thing I want to just point out real quick is Tahoe and the National Health Underwriters Association do a tremendous job in advocacy, but they can't do it without you. And the reason these rules are written that way is because the pharma PBM industry and the big insured agencies, good, bad, ugly, or differently, they really participate. There's nothing wrong with participating. It's just a reminder that if you want to affect these things, you need to participate and back your associations to get these messages, because EBSA and CMS beg for input from other than the big insureds. They don't get a lot of it, so they'll listen. So just, right, when they ask you to come to these legislative conferences, when they ask you to vote in, do it, because they need that input.
Yeah, and these, I know this isn't CE and you're getting to know my teaching style. It's really conversational, but these are the conversations, and I like to ask questions from y'all because y'all are boots on the ground in the weeds talking to clients. I mean, I'm compliance, right? I read black and white, and then I have to kind of put the pieces together. How is it working in the real world? And right now, I think a lot of clients just said, okay, UMR, PBM, TPA, whatever, y'all have my data. I'm going to pay you the $1,900. Oh, or I love this one now. Oh, you're doing it for free. Of course they're doing it for free because they don't want to get naked and show you where all your money's going. I mean, that's really what it comes down to. So yes, they'd rather do it for free than to be transparent. Really transparent on an individual plan-by-plan basis. So that was our RxDC. I spent a lot of time. I did get in the weeds on it. It's very fascinating because I want to end the shell game. And if y'all came last month, we had a PBM lobbyist here, and y'all might have thought that was unconventional. I'm okay with being unconventional because I get to see, one, I get to make that connection and know that she's advocating for PBMs. Now, as I'm learning, I get to go back to her and be like, wait a minute, how? And then you get the vertical integration. That really makes me mad because you've got these kickbacks going to carriers. It's crazy. And at the end of the day, it makes you wonder do we really want employer-sponsored coverage? We're going to nickel and dime right? If regulations and service providers are nickeling and diming our employers who give us our job and then write our paychecks, do we really fight for their interest in our field? And I have a lot of conversations with Mayhew, and I'm like, do y'all really want employer-sponsored coverage?
You really want the government?
Or conversely, are we doing these things that are leading us into a public option single payer system? And I'm not being Chicken Little, sky is falling. I'm putting these pieces together in my head, and that's how this is going, right? Can't keep doing this. Because again, these things, yes, the transparency is great stuff, comes down on the employer for the most part, and they're the ones that are going to try to get that information out there as they have to, but it needs to be out there in a way that can make a difference. So prohibition on gag clauses, we're still in the CAA. I'm going to fly through these because it's not too exciting. If you're doing your job, you're reading these contracts, taking out gag clauses, you're not going to let somebody tell you, no, you can't do that. no, you have to do that. Take out these gag clauses. There's supposed to be this attestation of compliance that you have reviewed the contracts and you have removed gag clauses. They haven't told us how to submit that, so it's on hold. Oh, shoot. The other thing about these, the CAA, majority of this stuff went into effect.
I got it.
Thank you. It's the Google one. Yeah, just up there. Went into effect, top right, January 1, 2022. So we're, slideshow. So we're, rounding out year one that the majority of this stuff has been done. Whether enforcement's been delayed, that's another question. But as far as complying, it's, we're in it. Mental health transparency, the PIA, this is going on our NQTL stuff. And guys, mental health Parity, Equity, Addiction Act was signed in 2008. It's not new. It had the NQTL provisions in there, the non-quantitative treatment limitations, step therapy, prior auth, how do things work behind the scenes. It also had parity between your quantitative, we're talking about mental health, substance use disorder, and medical surgical. So this has been around for a while. What the CAA did is it said, you're going to show me your work. I don't believe you. You can say it's on par. Great, that doesn't make it so. So show me your work, do an analysis, and again, this is on the plan sponsor who doesn't have the information because they're not the ones administering the plan behind the scenes, right? So did we go to the right person or the wrong person? I don't know. We went to the entity that will put pressure on the people who actually do the network, who are behind the scenes running the plan. So maybe that was intentional. Not sure. It doesn't really matter where it is now because you got to show your work. So this is another place where clients are having to pay, in some cases, to get their own plan stuff, right? Remember, self-insured plans, they are the plan. They own it. But now they're having to pay someone else to give them their stuff back. Right? It's like, no, it's my stuff. Give it to me. So let's look at our contracts that are coming up, your RFPs, your renewals. Let's line this out, guys, and make them tell us in those broker compensation disclosures, in those service provider disclosures, what they're doing and who's doing what. And if they don't charge you in the beginning, I wouldn't let them charge you when it comes to getting your stuff back. Give me my stuff. There are some people who are doing these, there are vendors who are doing NQTL analysis. It can cost a lot of money, and at the end of the day, it's probably going to come back and say, no, you're not compliant. No, you're not adequate. And then what are you going to do about it, employer, that has no control over how prior auth works or how many mental health providers you have in a network? You're not going to do anything about it because you can't. So if you're looking at cost benefit, probably deficient here, out of your control, save the money, spend it somewhere else. This is unsolicited, non-legal advice. This is strictly, all of this is my opinion. I didn't say that before. This is all my opinion. Every single bit of it. Which is why we're not doing CE. The top areas of non-compliance, so if you're thinking, like, what should I look out for? A lot of it's going to do on this ABA therapy, autism, blanket exclusions, opioids, nutritional counseling, and eating disorders. If you are restricting your eating disorder therapy, you're going to get sued. All right, those mamas want their children to live after they get out of eating disorder camp, so they will sue you if they have to pay it. Pre-authorization and pre-cert requirements, right? All this has to be on par. Now, grandfather plans, again, kind of get roped into this to the extent that they are doing mental health substance use benefits. Okay, so if their plan includes some of that, they're roped in on now showing their work. I do have a couple of plans that have really bad benefits, and they're okay with that. The No Surprises Act, Title I, this has about 17 provisions. This, again, effective January 1 last year. This year, we're in January. 2022. And, you know, Cynthia was saying is Texas was ahead on this. We have our own balanced billing state law, so that we got the report on that. That is protective, especially on our fully insured plans. But Texas, we chose, and I sit on the Texas Legislative Council. So when we were looking at these bills, you know, we chose to not go the ERISA route. All of our Texas bills are fully insured. This is before the Arkansas ERISA preemption thing, whatever. But we really weren't comfortable. We wanted to get something through. So our fully insured is ahead of the game on this. But this is helpful on your, you know, just in general, because it gets the air ambulance, right? And that's kind of big. There's a lot of dollars in air ambulance, and Texas isn't going to take on that because it's the FAA. So we're glad to see that this did help with unavoidable situations, and that's what it comes down to: is a person, and are they of the right frame of mind? Are they physically able to go to an in-network provider or facility and get in-network care? And if they are not, or they were in an in-network facility for an emergency, but your ancillary or not expedition, that would not be good. Not the one you want. Your anesthesiologist is out of network. You're not going to get balanced bill for that. Or you shouldn't. Now, does that mean it's happening? Absolutely. It's happening. It's happening all the time. So what do? Well, we advocate for our clients in your spare time. Report them. Okay, reporting is confidential in most cases. Report them. Let's get these bad actors. Maybe it's not even bad acting, right? Maybe they just need to get caught up and get on board, all right? But let's not leave our consumers in the wind. Might need to revise some SPDs and plan documents. And if there is cost sharing or out-of-network surprise bills, those have to apply to the in-network deductible. Okay, so even if something is on its face non-compliant, you can get back in good grace by using those limits to apply to the in-network deductibles there.
Can I say something? I think as a broker, you need to be aware of how this actually works. I had a situation recently where someone went in through the emergency room. It was an emergency situation. They were in the hospital, and the claim for the hospital was declined because it was out of network.
Not okay.
Well, when I actually called the insurance company, it was one of the major insurance companies, they said that the coding on the hospital bill was that it didn't come in the emergency room. Now, there was an emergency room bill at the same time. So it was kind of like, okay, you got an emergency room and you came back in the front door. I mean, that didn't make any sense. But so we have to understand how this works so that when our clients get in those situations, this was a $175,000 bill that was not pre-certified. So they said, stop paying. And so the client is sitting there going, am I going to get looking at a $175,000 bill? Well, ends up she wasn't, but those people don't come to you. They just freak out. And then, of course, we all know these doctors are going to bill you no matter what, hoping that you pay. So as a broker, you need to figure out how this works because your clients are going to get hung up in it. You need to be able to explain it to them and you need to be able to fight and advocate for them.
Right, and a lot of it does come down to coding.
It's all about coding.
It's all about coding. And so I've gotten to where I go into our little urgent care, which is connected to a freestanding ER. I'm like, there's not an invisible line here. If you even pretend to code me for something emergent related, you're going to get in trouble. I will turn you in. That is not okay.
But I do think it's important to understand you're right. And one thing is patient education. Some updates can really reduce the burden on you and increase the value. I'm having surgery on my ankle tomorrow, and it's been an educational process for the surgeons and everybody else because, of course, I'm checking my PPO and I want everything validated.
Exactly.
Well, none of the anesthesiologists are network and go, well, under federal law, you're required to tell me that in writing. And now they're all like, it's been an interesting experience, right? So they're learning too. But it makes a difference because the state regulations impute around costs and some of the stuff, but the federal rules apply to ERISA plans. But there are some state rules that come through what I do when I do pro bono work, which is more like when you're doing patient solutions, is I give the employers or the people that are trying to help samples to send it. And I just say, don't make the participant figure it out. Tell them to send this letter to everybody. The plan, the EBSA, which is the local office, has been here. They're lovely. You're trying to pick up the phone and call them. I know I'm not supposed to say that as the person that defends it, but actually we solve a lot of problems that way. The Department of Insurance and the medical board, if you just send a letter to all of those people, they will sort it out in 90% of the cases. And that, think about how much less stress that happens for your plan member, your employer, and you. Is just get it to the people who it's supposed to be, because they will educate these other people. And the good clients that are working with us and paying lots of money will not be punished because people break the rules. It'll work better. It just works faster.
No, I agree. So this, what I did get into the weeds, but it is having to figure out, like, what is the purpose of this? You have your insurance cards. There's a whole lot of information now on your little insurance card, right? Lots of phone numbers, lots of disclosures. Are we over disclosing? Are we over notifying? Do people read the stuff?
Can people read the letter?
Can people read the print? You know, so it should be clear. Should be a telephone number, website readily available, and you should. What's really nice is if you get told one thing, and a lot of these transparency and or the No Surprises Act. If your call center, maybe not nice, but if your carrier, if somebody tells you something, and that the provider was in network, and it turns out to not be true, the consumer is not on the hook, right? So a lot of this is consumer friendly, which means it's going to come back on the employer as the fiduciary to make sure that their stuff is up and running and current, right? And that's where those contracts come back in, and this is a lot of technology driven, right? We got a lot of technology in this room right here that can figure this stuff out. Clear writing, advanced EOBs, this is delayed until final regulations are issued, but you do have that good faith estimate. But I don't even know if people know how to read an EOB, so maybe start there, right? I don't know. Start there. Teach us how to read an EOB. Don't do this every day. Provider directories, this has to be updated. This is what I'm saying. So if I get told from my consumer delivery, advocate that I need to go here for this service, and it turns out to not be in network, I'm not in trouble. Okay, so there's some education that comes into that too. So I document my calls that I didn't used to do. Right, so some consumer education too. Price comparison tool. This was an overlap with the TIC, so again, your grandfather plans might think that they were out of this specific individualized transparency tool. I mean, this is pretty cool, right? As a consumer, we should be able to go online to our carrier, to our PBM or TPA. We should be able to plug in our name. It should pull up our coverage that we've enrolled in with our real-time deductible out-of-pocket, right? It should know everything right there and tell me who I should go to based on quality, geographic location, and cost. That should be happening, guys. Like now, well, in a couple of months, okay? So, I mean, that's pretty cool as a consumer, right? Don't we really want to know what something costs?
Go to Medical City Squad's website and see what it costs. You won't be able to get that.
You don't get it, right? You don't get it.
You have to have a policy number to give them all your medical information. You can't even,
Well, and so that goes to the hospitals, not.
If you offer the cash price, you get call this number.
Yeah, the hospitals don't care. They're not having to, that they can afford to not get in line. Our employers can't, right? So this again, we're going after employers. This is all on the employer to make this happen. And so do we really want employer-sponsored coverage? Do we really want to know what things cost? Do we really want to get control of our healthcare spend? I don't know. Do we? If we do, then we need to figure out how to make this helpful from that lens. COVID-19. Do I have? I've talked a lot, but I'm going to go through this COVID-19 because this is kind of, I think, still important. Why are we still in this public health emergency, this PHE, right? So we've got the public health emergency, the national emergency, Medicaid unwinding. That's all COVID. So PHE, that's a public health emergency. It started March, I think it was declared March 13th. Goes back to March of 2020, 2 years ago when the world stopped, right? Almost 3 now. This is where your COVID diagnostic testing without cost sharing, whether in-network or out-of-network, so that's important. While we are in this, we are still in this PHE, this is public health emergency, out-of-network COVID testing, diagnostic, and now also includes RSV, flu stuff, all of that, even at out-of-network, should be in-network covered. And this applies, I think, on your Medicare plans too, so across the board. Medicaid, all of it. So I've got a lot of stuff on here for Medicare. I did learn a lot about that. Still part of the PHE, Biden let us get up to 8 free, nothing's free, 8 free at-home testing, COVID tests per month per individual, as long as this PHE goes. That's a lot of false positive tests, guys. A lot of false positive tests there. You can get reimbursed up to $12 per worthless test if you want it. No prior auth, no prescription, no medical provider involvement there. So when this ends, COVID testing might diminish a bit because people will have to pay for it. When this ends, when will this end? I'm not sure. Preventive services again.
They just extended it.
I know, they just extended it again. So we're into mid-January. It's like, really? Okay, so we've got more vaccination. That is now part of preventive services under the ACA. So your COVID stuff or non-grandfathered plans is part of preventive care. Okay, it just is. There was a lot of, so what does free testing and diagnosis and other related services mean for our high mental health plans? Well, it could have made you HSA ineligible, but the IRS waved a wand and included that now in, preventive care. It can be zero cost share, or it can have cost sharing prior to meeting that statutory deductible to maintain HSA eligibility. Telemedicine, lots going on in telemedicine. The important thing there was do I have a slide on this? Yeah, telemedicine, and this is group health in particular. Your high deductible health plan and HSA eligibility, right? You can have your telemedicine. You don't have to charge the fair market value right now because we're in this PHE, so you don't have to do the fair market value on any of that. There is a safe harbor through the end of this calendar year if you wanted to maintain that $0 cost for your telehealth. That's piecing together some IRS notice, some CARES relief, some CAA relief. But I do want y'all to understand that there's still this ACA market reform for freestanding telehealth. What do I mean by freestanding telehealth? Telehealth that is offered to participants that are not also enrolled in your medical plan. Okay, so this is an ongoing thing. The DOL has never really given much mind to it, but they did call out specifically that they know that telemedicine is a group health plan. They know it's not satisfying ACA market reforms, and it can't, by design, satisfy ACA market reforms, which is $110, maybe inflated per day per participant penalty, plus your ERISA notices and disclosures that go with group health plans. So, Operation Shout from Navy, we are trying to free telehealth and free our HSAs. So, if you are not getting Operation Shout, why not? Let's find out why you're not getting them, because there have been a lot of bills on telehealth, making telemedicine a HIPAA-accepted benefit so that it gets out from under our ACA market reforms, making it to be forever, playing nicely with HSA eligibility. So that's something there too. A lot of stuff happened in Medicare. The CA did remove audio and visual requirements for telehealth. I thought that was pretty cool. Y'all probably knew that. You could FaceTime and Skype for audio or for Medicare. You don't just have to be in rural areas. Some of these things will end though after the PHE. Cross-payer, all states allow physicians to go interstate. Some of it has drawn back. Thought that was pretty cool. Medicaid, a lot going on in Medicaid unwinding, which is why the PHE was apparently.
So back to Medicaid unwinding. This is something that's going to be the next big wave because during the pandemic, if you were not eligible for Medicaid, not have to be certified. When the public health emergency goes away, there are going to be thousands of people in the state of Texas who are covered by Medicaid who will now have to be certified and will not certify as Medicaid. So this is going to be a big deal. We're kind of talking, the Tahoe board is talking about doing some things to try to help with that because it's going to be huge because there's going to be all those people that are not going to be eligible for Medicaid. They may or may not be eligible for a subsidy. So there's just going to be a big rush of people now. So that's just something, if I were you guys, I'd be watching up on because that's going to be.
Yeah, and hopefully between us, we can get some good collaboration. And Fort Worth, obviously Fort Worth here too. So if we can get our heads around what this means for the Metroplex, that could be pretty impactful, guys. We're not going to expand Medicaid.
Yeah.
I mean, so we might as well get those who are eligible on it, and those who aren't, give them some options. Okay, so the other thing that really makes me mad is this national emergency outbreak period. I think everyone's kind of forgotten about it, but this was first declared again March 13th, went back to March 1 of 2020, and the purpose of this was communication. The world stopped. Employees didn't know where they were going to be. A lot of employees lost their jobs. They went strictly remote, had to get set up. So now plan sponsors have these fiduciary obligations to communicate with their participants by way of notices. And participants have an obligation to participate with the sponsor by way of notices. And there was a lot of confusion. People didn't know where they were going to be. So there was this delay called the outbreak period that in 60 days after the national emergency. So that's different than the public health emergency, the national emergency. And no one seems to care. It's so what does this mean? This means that there are certain deadlines that are told. So this does not apply. Well, you might want to check if you have school districts, quasi-government plans. You might want to check to see if they actually slipped in adhering to the outbreak period, because what it means effectively is that individuals who had either a HIPAA special enrollment event, so marriage, birth, divorce, loss of coverage, or COBRA for whatever reason, their window to notify the employer to get on or off the plan, whichever it may be, is open. And it's open for up to a year. That's nuts. And we're seeing litigation now. I'm starting to see the litigation come down of, and if I'm seeing it, that means it's happening more than I'm seeing. That means people are suing because they didn't get their notices, their COBRA notices. You know what else happened in here? We have ARPA. So it's a great time to go back to and tell your employers to go to their COBRA provider or TPAs. Go ahead and unsolicitedly give your employers their COBRA forms, their COBRA notices, so they can reconcile, because they've got people literally hanging out since, September 2021 that can turn around and get on their plan and have all those claims paid, right? Or retro. If they can pay the premium, right? I mean, of course, there's that. But if you're needing to get coverage, maybe, I don't know. But that's big. We need this to end. I don't know why this won't end, but we need it to end. So this also applies to claims and appeals, denials. So you can see there's a list of the things that are just hanging out, open, and less than a year has lapsed, 60 days after. Employer to-dos, and I'll wrap this up, guys. Review your COBRA vendors, review carrier contracts, review all your contracts, or tell your clients to look for disclosures of compensation, try to figure out how we can make transparency really moves the needle for change. Because it's not going to the way we are right now. And that should make you mad. Made me mad. Because we sit on these conferences and these calls of how can we control healthcare costs? Well, you can't if you can't see the stuff. So the data's getting out there, step one. But we need it to get out there in a way that can move the needle. I'm so tired of talking. A little bit more. Next month, we're doing dependent audits, why those matter, and they do matter. They matter a lot. And if you want to be a sponsor, we'd love to have you. The next month, we're probably going to do a happy hour to be continued, or to more details to follow in our newsletter. And then in January, we will be at.
I'm tired. Are we adjourned?